Welcome, everyone. I'm going to wait for other people to join us, give people a couple of minutes. We're expecting around 50 people, so we'll give people a chance to log on and swell our numbers. So we have some people joining us. We'll give everyone a few more minutes to do that. Okay, participants are signing in. Alrighty. We'll give people another minute or so, and then we'll start our program. Oh, a nice hello to Mr. Baldwin. Lovely to see you today. So, I'm going to do a few introductions, and as more people join us, then we can start our program formally. So, my name is Nellie Brown. If you haven't been to one of my workshops before, I'm a certified industrial hygienist, and I direct the Workplace Health and Safety Program, which is part of Cornell University School of Industrial and Labor Relations. Today's program I'm doing for our colleagues here at Cornell, who are the Worker Institute. And I'm hoping that you all will join us for other programs in this series, which will continue for about 10 programs right now, which will be delivered the second Friday of each month at 11 a.m. On a variety of topics. And of course, today we're going to be talking about, of course, the pandemic. What else? So I'm going to be joined today by my colleague Veronica Moore, who will be handling the Q&A. So if you have questions today, please put them into the Q&A. That way she doesn't have to watch the chat box as well. It becomes bewildering when you have to check for questions in too many places. So please put them into the Q&A. And I will start sharing my screen and we'll begin our program. Okay, so today's workshop is intended to take a look at some of the fundamentals about SARS-CoV-2 and our issues of returning to work, but particularly focusing on what's different about the pandemic now, what have we learned over the last year and a half, so that we can, of course, make good decisions about returning to work, particularly for offices and schools. So today I'll be discussing some basics. As always, I like to make sure I have fundamentals always covered and we can build on that information. So we'll do a little bit on the virus itself and its mutants and variants and see where we are with that problem. We'll take a look at how it's acquired and spread at work. Again, a few things that we've learned or changed since the pandemic began. We'll target a few specifics about what is different about the pandemic now at the current moment. We'll explore the regulations and recommendations that we have for preventing, of course, this disease from entering and spreading in workplaces, drawing on ways that we can reduce, of course, our risk using the hierarchy of controls. Now, the thing about, I think, disease in most workplaces is that if you don't work in healthcare, you're not accustomed probably to looking at your workplace through what I call the lens of communicable disease. Because healthcare is where people tend to assume that workers will encounter disease, known or suspected. But the reality is that disease spreads in all kinds of settings. Other diseases are still around. We still have to address the flu and colds and other respiratory infections, gastrointestinal illnesses, the usual stuff we spread around when we're in contact with other people. And this has been, for the last year and a half, a new sort of lens to look at workplaces for so many non healthcare places. So, when we first observed coronaviruses some time ago, their name was given to them of coronavirus because the idea was it looked a lot like the corona around the sun. And of course, we recognize we have the common cold caused by about 20-30% of our colds anyway, are caused by a variety of different coronaviruses. So we have seen this kind of virus before as a family of viruses with this particular structure and shape. Of course, it's not so pretty when you see coronaviruses attacking one of our body cells, as you can see in this picture. This is a real assault. And of course, with our technology, we have very early on in the pandemic been able to map this virus quite well. And in fact, elucidated these spike formations on it and have been able to understand a lot about how this virus proceeds to attack body cells and how it's been mutating. Now, remember, a virus is not a living cell. Living cells, like you see in the figure here, have a lot of machinery. They have a nucleus where they keep their genetic information. And then around the rest of the body of the cell is all kinds of machinery by which the cell can grow and reproduce, manufacture more parts, repair itself, and so on, as well as generate the energy to do all those sorts of processes. A virus, however, is not like that. A virus is very much like a nucleus in the sense that it's a bit of genetic material surrounded by a coat, in this case, a protein coat for viruses, whereas some people like to say a virus is a little bit of bad news surrounded by a protein coat. So a virus carries information, but it does not have the machinery to reproduce itself, which it accomplishes by attacking cells. So it gets into our body and it hijacks our body cells, and it forces those cells to manufacture virus components for it using the virus's genetic information. Now, those new viruses go off from the host cell on to attack more body cells, keeping the infection going, of course. So this is very much an assault. It's as though you had a bunch of parachutists from an enemy parachuting into a plant that makes air conditioners and saying to the plant management, you're not going to be making air conditions anymore. You're going to be making instead rocking chairs. Now, as these viral components are manufactured, they self-assemble. As you see in the lower figure, viruses kind of assemble themselves from their various parts that the cell is made for them. And in the process, then, of course, they snap together and then escape the host cell and go on to attack other cells. Now, as it turns out, with SARS-CoV-2, it attacks two cells that can attach to those viruses' spikes. Now, we have cells in our body in a variety of places where SARS-CoV-2 can attach. It is well known to attach to cells in the upper and lower respiratory tract, but also to cells in our gastrointestinal tract, to cells lining our blood vessels, and even to some cells in our brain. Now, we have observed over time with this virus that it does have both common and uncommon symptoms. And those symptoms can vary. On average, people who are infected will show symptoms, if they do at all, in about 5 days, but we have seen it range from as quickly as 2 days to as long as 14 days. And people can spread this disease before their symptoms appear, assuming they get any. And in fact, it's believed that transmission may in fact be heavily done by asymptomatic or pre-symptomatic people. And as a result, people who don't even think they're ill are not necessarily motivated to stay at home when they're sick. And as a result, this disease gets spread around very efficiently. Now, what we have found is that besides the symptoms that people get, some of which can be pretty intense, but in the hospital, even killing them, we also have some things that seem to be prolonged. And we've been calling this long COVID or long haul COVID. Now, of course, early on, we thought this disease was heavily affecting only the elderly or immunocompromised people. We've discovered over time that is not the case. And in fact, even the people with long COVID, 20% of them, one in five, are in fact young people, people who think they're not vulnerable and who have, in fact, a rather low vaccination rate. Now, we think that the virus often hides in parts of the body which are not as accessible by our immune system. Places like the central nervous system, the eyes, and the prostate, which may keep this infection going for quite a while. And as a result, our body's not always overcoming it well on their own, which is why having a vaccine is so valuable. We are also seeing some interesting relationships here in which people are experiencing chronic fatigue syndrome, something that is well known to develop after acute viral illnesses. And so we're seeing that here as well. We've also had researchers develop a new blood test, which we think will give us early indications that other body systems besides our respiratory tract are being seriously affected. And we might be able to, as a result, head off some of the more serious injury. But among all these various things you see here at the bottom of the slide that have been reported as long COVID symptoms, among the recent research that is very scary is what we're seeing as damage to gray matter in the brain. Changes that some people say are suggestive even of early Alzheimer's. And as a result, this is a very scary illness. And even though we have people thinking that, well, most people, it's just like a cold or the flu, but the reality is that the risk of developing something severe is there, and we can't at this moment predict who among the population would get infected and get long COVID. And as a result, we try to protect everybody. Now, in a recent analysis of private healthcare claims, we've been seeing about 23% or so of COVID patients having at least one post COVID condition. But the risk goes up if you've been hospitalized with coronavirus. 50% have shown severe cases where we have long COVID then showing up. And even in people who were sick but asymptomatic, in other words, they knew about their infection only because they'd had a COVID test, 19% of them are in fact showing up with some types of long COVID symptoms. Now, the most common ones tend to be things that you see here pain, breathing difficulties, excess fat in blood, the hyperlipidemia, malaise and fatigue, and hypertension. But we are seeing, as I showed you on the previous slide, people with serious organ damage that goes beyond some of these symptoms. I know for myself in recovering from coronavirus that, because I caught it very early on in the pandemic, that the fatigue lasted for months. Now, when it comes to this infection, we have to recognize that SARS is a virus which encodes its genetic material in RNA rather than DNA, which unfortunately allows a faster rate of mutation. And as this virus infects its next victim and reproduces in that next victim, it has errors in its replication. Now, these errors and mutations can, in fact, be trivial, like changing the paint color on your house. It's still the same house. But some of these mutations are, in fact, making this virus into a better pathogen. And over time, we have observed variations which, as people began to deal with more and more of these mutations, the World Health Organization began assigning them letters of the Greek alphabet as a way to distinguish them. Right now, the most common infection in the US is the Delta variant, which unfortunately has developed two very significant mutations that enable it to attach to our body cells more forcefully, therefore guaranteeing transmission of the infection. Unfortunately, when working from home, I have a cat Here, play with the ball. There you go. Go for that. Okay. So we still continue to see more mutations developing around the world, including some in the US. One of them we're keeping our eye on right now is this last one, the mu mutation. And mu has some very preliminary information suggested that it may be able to evade some of the antibodies that we make in response to infection or vaccination, in which case this would need our vaccines to be accordingly modified to match this. Now, I'd like to point out to you that when we have mutations occurring, people are often concerned about mutations becoming a more deadly infection. But actually, it's considered to be a more dangerous problem when a virus mutates to become a more contagious variant, which is why we've been so concerned about Delta. And the reason is, let me give you a comparison here. If a strain after about a month has been affecting people and it's a 50% more deadly strain, it can cause 1.5 times the number of deaths of the original virus. But a 50% more contagious strain spreads among so many more people that the resulting number of deaths actually increases 11 times. Again, more people infected, more people can die from it. So, in fact, breeding this virus to become more contagious is really the more nasty type of mutations can occur. And this is the reason why we have to get as many people vaccinated as possible. We cannot afford to have more people infected. Even if some of them experience only mild infection, the reality is they can breed more dangerous variants. Now, let's take a look at what this means for spreading a virus in the workplace. We recognized early on this disease is found in respiratory droplets, but the concern initially was about the larger droplets. Over time, our aerosol scientists from around the world have been urging the World Health Organization to understand that this is an airborne disease and the virus is spread in all kinds of sizes of droplets, not just large ones that you get when you're really close to someone or the large droplets that drop close to you, but rather also the small ones that are carried in the air, spread around, and reach people and can be inhaled very deeply. So, when we look at our classic routes of entry, this is an airborne disease and we're very concerned about it. Recent studies in guinea pigs looking at droplet sizes have said to us that the problem with inhaling the virus is that it deposits more deeply into people's lungs, and as a result is more likely to produce an infection accompanied by more severe lung damage. That means that when we concentrate on our workplace controls, we want to address airborne virus of all different sizes of droplets. So we use a variety of control measures for that. Now, what about these other routes of exposure? Well, the animal studies say that fomite transmission, in other words, from touching surfaces contaminated with droplets, can also occur. It is real, but its risk is very, very much lower. And what happens is people who are touching their face and rubbing their eyes, or touching a surface and picking their nose, rubbing their eyes, touching their lips, we touch our faces some 15 to 25 times an hour, believe it or not. These things also can result in transmission, which is why we try to avoid those types of behaviors. We try to improve people's hand washing and so on. But what has shown up in the animal studies is that this type of transmission route tends to result in the virus replicating in the nose, which gives our bodies a little extra time to attack it with the immune system. In other words, respond to it uh, faster than what it could take to get the virus further down into the deep lung. So the airborne route is really our most important one. Now, I do point out to you that if you're close to someone, droplets that they put out can land right on your lips. We lick our lips, our mouth is a mucous membrane, it's a route of exposure. We can have hand to mouth transfer if we've not washed our hands well. And then we, of course, eat or smoke, we transfer things to our mouth. Sometimes we take an object that's been contaminated and we hold it in our mouth. We don't even think about doing that. with a pencil or pen, a comb, or whatever. And of course, sometimes people have habits of nail biting. I also draw your attention to the fact that the mucous membranes in the eyes and the respiratory tract are connected to each other, which is why when you cry, your tears drain into your nose and your nose runs. This is why we get concerned about being close to people, because droplets from them can land in our eyes as well. Now, when you think about this airborne transmission route, and we want to tackle it in a workplace with good control measures, keep in mind that these droplets, can be of a variety of sizes. Some of them are known to be large enough to drop literally within 1 meter, about 3 feet of your body. And in fact, a review of some 200 studies from around the world has showed that if you keep at least about a 3 foot distance from people, your risk drops already dramatically. And then for every 3 feet after that, your risk drops another 50%. So, yes, keeping your distance helps, avoiding crowds helps. But the tinier droplets can, in fact, travel and be carried by air streams. So, is the issue really with them? Well, we suspect that viruses may even be enriched in smaller aerosols. As they're propelled from our face with breathing, singing, exertion of all kinds, any kind of exercise, those droplets, travel through the air. They can evaporate. They're exposed to the ultraviolet light of the sun. Airflow and ventilation make a big difference. They can evaporate to smaller sizes, and as a result, be carried around a room or even into recirculated air through a ventilation system. This is, of course, why keeping our distance helps, why wearing masks helps, improving ventilation and filtration of air helps. These are all important considerations. But of course, you have to always keep in mind that face masks are removed in areas where people are eating or drinking. And if you're in an area where there's a lot of loud background sound or music and so forth, people are going to speak more loudly and forcefully. And the result is they produce more aerosols and propel them with a greater velocity. Now, how important has this disease become? Well, as we reflect back on it, for calendar year 2020, it was the third leading cause of death in the US. And of course, if you look at how we've been addressing this disease, we thought we were getting some really good control on it. And then more recently, we've seen a bigger surge. Again, the result of the mutation rate and the production of the Delta virus. However, there are people who've been modeling this disease who believe that a lot of this disease being asymptomatic, that probably a lot of our cases were in fact underreported, and that maybe as many as 1 in 5 Americans have actually been infected with it. But so far, we've been able to document 40 million cases based upon, of course, our testing and so on, and over 600,000 deaths. And we're in the middle of another, it appears, wave. So, what's different now that we should pay attention to? Well, we're in another surge, and some of the things that were true for the original virus are not necessarily holding true for the newer mutations, these new variants. And we are seeing some issues of waning immunity and immunity even for vaccination that we've done for infection, even though we're not seeing quite as much issue here with hospitalization or serious disease. Now, this kind of waning immunity that we have seen has made this issue become a little different than early on in the pandemic. We also have seen hospitalizations reaching a big peak and vaccination rates, unfortunately, lagging. Some of our most recent data says that our vaccination rate is nowhere near as high as it should be. We're thinking it's at about 73% or so of those who are eligible for it, keeping in mind that there are some people who are not eligible, and including children under 12. And we think that because of that, this low vaccination rate that we have in so many areas around the US will keep this disease endemic. We'll talk a little bit more about that towards the end of our workshop. Now, early on in the pandemic, most of our major health insurers were voluntarily waiving a lot of the costs associated with COVID treatment, and they were keeping tests free. And this was very helpful. But during the latest wave, we're seeing a little bit different situation here with insurance carriers. I'm seeing news in various insurance publications saying that routine tests and lengthy hospitalizations are likely to cost adults a lot more money than previously because we have vaccine now. So some insurers are saying, well, then we should be treating COVID-19 like any other disease, and perhaps they'll increase our charges for it. We also are finding that despite enormous amounts of research on COVID-19, we still don't have a consensus on what an infectious dose really is. We've got this sort of vague description saying, well, if you're around someone for a cumulative total of 15 minutes, you can be, that we're considering that real exposure. And we also still do not have good consensus on not just the air sampling, then could we use that better, or surface sampling because of this. Now, with this very highly contagious Delta variant, we're seeing a virus that, because of its mutations, is getting into cells more easily and replicating more effectively once it's there. So, when you think about this, the original SARS infection was spread on average to another 2 to 3 people, but that was really an average. We tended to find most of these cases were really being spread in what we called super spreading events, where a few people were very contagious, spreading a lot of airborne virus to a group, and we saw this super spreading event kind of situation. But for Delta, we are finding that its ability to attach to cells is so effective that it is able to be spread by one infected person to another 5 to 9 people. So the idea of super spreading events isn't really applied so much anymore as a term because this has become a very, very successful variant of this pathogen. Now, when you take a look at what we're seeing as the pattern of the pandemic, we're seeing almost all the coronavirus deaths occurring among people who were not vaccinated because of this strain being so effective. Now, I do point out that when this Delta variant infects people, both vaccinated and unvaccinated, the level of virus in their sinonasal tract is at about the same level. But in the people who are vaccinated, those high levels seem to last for only a couple of days. At least one study is saying that. And so we're watching these viral levels drop quickly in people who are vaccinated. So they are, in fact, a lot less infectious to others. That's again, value of vaccination, an extra value people don't always think about. But once more, we need our masking, our social distancing, etc., to help us buy time, to try to not overwhelm hospitals. As much as we can do with that is helpful because many places, hospitals are being seriously overwhelmed. Now, early on in the pandemic, the victims tended to be elderly or with pre-existing conditions. We've gotten a lot of the elderly now vaccinated, but we do still see a risk for the pre-existing condition group, which is why for people who are, for example, immunocompromised, we're beginning to recommend boosters. But we are observing that a lot of the victims now tend to be younger. About 20% right now are being spread among children. Again, children under 12 cannot yet be vaccinated, so they're a high-risk group for that reason. We're also finding the vaccination rate among people in their 20s and 30s is really not anywhere near what it should be. These are people who think of themselves as strappy and healthy and at low risk, which is ridiculous, which is why we're seeing them in hospitals. We're seeing some of them die. And this is not a group that can literally judge on their past health and say, oh, I'm not likely to be seriously affected, because some of them are, even despite a past history of being very healthy, strong, resilient people. Now, as we put into place all these control measures for COVID-19, we've been seeing influenza, respiratory syncytial virus, and other diseases at historic lows. But that's not, of course, a guarantee for this upcoming fall flu season. So you do want to get your influenza vaccine kept up to date. Now, of course, early on, the groups that we saw being seriously affected were the people that we thought of with compromised immune systems that we've seen historically be at risk. But for coronavirus, we had to add a few other groups, people who are older, people with histories of asthma, COPD, and we raised questions about people who were pregnant or obese or had kidney disease and began to see numbers in them too. So, this is why we try to vaccinate as many people as possible because we need to protect the most vulnerable among us. So let's take a look at a few of these issues that have cropped up with the pandemic. What have we learned? Well, we've learned that if you're pregnant, your risk of infection having a severe outcome is in fact greatly increased. This is why we are encouraging pregnant women to get vaccinated. We have seen that over the pandemic's course, a higher rate of cesarean deliveries and an increase in preterm births in women who have been infected. We're seeing some reports of infection of the placenta and some very preliminary information suggesting that coronavirus may, in fact, be able to cross the placenta and affect the fetus. We're seeing some blood vessel malformations on the fetal side of placental circulation caused by this infection. Again, that may contribute to the preterm birth, etc. Now, if the mother is infected at delivery, the baby may be infected too. We're seeing disproportionately affected high risk groups among Hispanic and non Hispanic Black women as well. Now, for some of these pregnant women, we do recognize obesity and gestational diabetes being an additional risk factor. Now, if we take a look at pregnancy and COVID-19, we have recognized the fact that vaccination has tremendous value. And in looking over the past experience with the vaccination of women in various stages of pregnancy, we've recognized that vaccination does not increase any risk of miscarriage in the first 20 weeks of gestation. These vaccines are, in fact, very safe. We've also discovered some nice outcomes to getting vaccinated. We're not only seeing a robust immune response in both pregnant and lactating women, we're also finding vaccinated women passing protective antibodies to their fetuses, protecting the child. We're seeing SARS-CoV-2 specific antibodies present in breast milk after vaccination of breastfeeding women as well. So if they didn't get vaccinated during pregnancy, to get vaccinated during breastfeeding is also valuable because you can pass these antibodies on to the child in your breast milk. And we've found that the vaccine is itself not damaging the placenta. Now, we're also recognizing more things over time with children. Now, we have seen through the pandemic that children affected have tended to heavily be asymptomatic and also less vulnerable. And we're still seeing them less vulnerable than adults for Delta, too. But if you look overall at the 3.5 million cases we have documented so far of COVID-19 in children, the death rate has been only 0.015%. In other words, about 519 fatalities so far. And that means the risk for children is very low. And we're beginning to understand much about this. But what we can say about it at this point are these following learnings. Now, we think that a mother's respiratory inflammations, in essence, train the child's immune system during fetal development to develop more long-lasting memory against viruses. In other words, a mother's respiratory history helps to train the fetus. We also recognize that the receptors on our body cells the virus attaches to, the ACE2 receptors, tend to increase in our nose with age. They're rather at their lowest numbers in children under 10 years of age. And then as the child grows up, more and more receptors are formed in the nose, with the highest reaching our adult at about 25 years of age and staying high throughout adulthood. This suggests that as a result, children are less likely to be attacked because they have less receptors in their nose. So that is some help. We also recognize that a children's immune system is not yet well developed, and as a result, they are less likely to produce severe inflammation, the kind that in adults produces what we call the cytokine storm. Now, children, even if asymptomatic, can still develop multisystem inflammatory syndrome, so the risk is there for children. even though it is indeed rare. We also recognize in our studies of households with very young children, 0 to 3 years, are able to transmit the virus more easily within the household than older children because they require a lot of hands on care. And you can't isolate a child like that when they're sick, they still have to be cared for. Older children, however, when you get to the 14 to 17 years of age, more likely are acquiring the infection hanging around with other kids outside the home. Now, if you look at the past history of the pandemic for the previous school year, you tend to find that children who were infected were more likely to have gotten it through various social settings involving gatherings rather than in the school situation. Again, because we tried to do as much as we could with mask wearing and ventilation and so on, as well as, of course, our remote schooling options. The question is, will this year's pattern hold for the Delta variant? Now, here in New York State, we have already seen the governor announce that she's working towards mandating COVID vaccination for school faculty and staff on top of the mandatory mask mandate that she imposed last week. Now, the Delta variant, in terms of school risk, is indeed an issue there if we do not do control measures. So, what happens if someone is infected and unmasked? Well, I want to share with you one such case. This was a case well investigated by the Centers for Disease Control. It involved an elementary school, in other words, students too young for vaccination. The teacher was both unvaccinated and symptomatic, and she went on working for 2 days before she got her COVID test. And she read aloud to the class while being unmasked, which of course means more forceful speaking even than ordinary speaking when you're reading aloud to a group. Even though the school required masking, she removed her mask to do this. Now, if you take a look at the figure, you can see how many students in the sort of pinkish mauve shading got infected from her. This is again why control measures in schools make a difference. We want people to be wearing masks, to get vaccinated if they're eligible. That's how we protect the children who cannot be vaccinated. And of course, to stay home if sick and to do routine testing in the school of those who are unvaccinated in order to catch them as early on as possible. Now, looking at some of the data on children and adolescents, we found that if you looked at hospitalization in those children, you found it increased fourfold in states with low levels of vaccination. Again, it allows the Delta variant to spread very readily, compared, of course, to states with high levels of vaccination. We also recognize that when you're trying to prevent hospitalization in adolescents and so on, we again saw hospitalization rates higher, 10 times higher in unvaccinated adolescents, and of course, increased as well in the very young children. This is why we need to vaccinate any child who's eligible, as well as all the faculty and staff who come in contact with children. Now, people, of course, are trying to do modeling and everything else to do predictions of how the school year is going to go. This is what we are seeing predicted so far. Again, it's a prediction. We don't know it's necessarily going to come to pass. But one such prediction is saying that significant transmission is possible if interventions are not done. In other words, we don't do masking, testing, improvements to ventilation, keeping students separated from each other, cohorting, all the things that we can do as control measures. So this particular model says that for susceptible students within the first 3 months of going to school, if there in fact is no masking and no testing in their school, over 75% of those susceptible can become infected. Now, if you simply use masks, you drop that number for the susceptibles at 50%. And if you add in testing of your students to catch the cases early on, and you do masking, you can drop the infections even further to 22%. So, yes, the more interventions we do, the better we do protection. Okay, so let's go on to look a little bit more about what's different about the pandemic now. Well, we're recognizing that vaccines have begun to vary as to their efficacy. Now, it's important when you look at vaccine efficacy to decide what is the endpoint you're going to look at. So I'm going to show you all three of them. I'm going to show you efficacy for preventing infection, period, infection for serious disease, and prevention of death. Because, of course, the variants change the efficacy numbers. So we'll look at that. Now, we do know that vaccination after an infection produces even better immunity. So we want to say to people, even if you did get infected and recovered from it, get yourself vaccinated anyway. In fact, even one course of the vaccination, one shot, does boost immunity dramatically for people who have recovered. But we're saying to people, please don't go out and get yourself infected intentionally. Have an infection party because you never know. Someone might get seriously affected by infection or might even die. So let's not try to go out and do that. Now, the people vaccinated very early are indeed showing waning immunity, and our preliminary information suggests that a booster shot can make a big difference. So, we're going to be exploring that and attempting, of course, to do those boosters in the US. Now, most places, when you look at their risks, have taken a serious look at mandating vaccination in the workforce. Now, many hospitals have already done that, non healthcare workplaces, many of them have begun to do that as well. Some were simply waiting for the FDA to give full approval of a vaccine, not just emergency use authorization, and say, well, when that happens, we'll mandate. And so many more have jumped on the mandate bandwagon with the first approval with the Pfizer vaccine. Keep in mind, it's not the vaccine save lives. You've got to get vaccines into arms to save lives. So let's take a look at this issue of efficacy of vaccination. So if you take a look at these various vaccines for doing what we really need them to do, which is these first two columns, preventing severe disease or death, preventing hospitalization if we can, performance has been remarkable. Remember, a vaccine was able to get approval if it could do at least 50% reduction of these things. We're doing far better than that. We're up in the 80 to 90 percentile for most of these vaccines. Now, of course, some of them we've got approval already in the US, others not yet in this country, but we are seeing some good data from other countries to say what's happening. Now, with the Sputnik vaccine out of the Soviet Union, which has been purchased by many countries, we are looking at phase three trial results rather than bigger population data. Now, with the vaccines in the last line that have come out of China, the efficacy has not been as good. Many countries have, in fact, bought this vaccine and have not experienced very good prevention with it and are often doing second shots or booster shots with one of the other vaccines to try to augment those numbers. Now, if we look at the last column, preventing infection at all, even if all you got was a cold, or you only knew you were vaccinated if you'd gotten a test and so on, and that's how you knew you were infected after vaccination or whatever. So here we're looking at transmission still occurring. So yes, we are seeing some of these breakthrough infections with the Moderna and the Pfizer. But the reality is we're still seeing very high responses to the Delta variant when it comes to preventing severe disease or death, which is what we want a vaccine to really do, okay? All right, so, and when you looked at real world effects, for example, as of this last spring, an in-depth study of first responders in healthcare and other essential jobs, it was found that over 90% reduction in infection. But when we began to look at this same group as of August of 2021, We were looking at comparing the effectiveness for the Delta variant, and it has indeed decreased. Still very good, well over 50%, but this is beginning again to show us why we think boosters might be a good idea. Now, when it comes to breakthrough cases, why do they happen at all? Well, when you're given a vaccination, your body is stimulated to try to produce the right shape antibody. Your body is capable of producing 10 to the 15th power variety of antibodies, but it doesn't mean that you still are able to make the right shape. You still have to do it using your own body's genes. Well, sometimes people simply can't make the right shape. And that's what we say for other vaccines too. For example, we say, well, hepatitis B vaccination is effective in adults at about 90%, 95% in children. Some people simply can't make the right shape, no matter how much you stimulate their bodies. Well, sometimes new variants are just not completely inactivated by the antibody shape your body is stimulated to make. The bonding is not real good, and things like that. So your white blood cells are not able to recognize, oh, here is an invader attached to an antibody. I need to eat it because that's what your body does. That's really the value of making antibodies. They attach to the invader. Your white blood cells recognize this signal of, wow, an antibody attached to a virus. I should go and engulf it and destroy it. Now, of course, when you look at our population overall of who's been fully vaccinated, the breakthrough cases are down around 1/100th of 1%. It's not a big risk. We think that on average for our population, the risk is probably somewhere around 1 in 5,000. But if you are in a geographic area like, say, northeastern US, where the vaccination rate has been very high, the risk probably drops down to half of that, to 1 in 10,000. But we are recognizing that the Delta variant is increasing our proportion of breakthrough infections. But if you look at the serious outcomes or death that we're seeing, over 90% of them are in fact among the unvaccinated, which is why we're now calling this a pandemic of the unvaccinated. Now, immune systems in vaccinated people do ramp up and fight the infection much faster than people who are unvaccinated. So they're contagious for a shorter period of time. But it's discovering this that is the reason behind why even those people who are vaccinated should continue to wear masks. If you get a breakthrough infection, you're still less contagious to other people, but with a mask, you can reduce that even further. Now, we know that if people have had a prior infection and they get vaccinated to boost their natural immunity, their risk is even greater. Rather, their protection is, of course, even greater. Being unvaccinated has twice the risk of reinfection compared with being fully vaccinated, if in fact you were infected once before. Now, what about the risk of long COVID for a breakthrough infection? Well, we know very little about this so far. What little information we have suggests that people who are fully vaccinated are 50% less likely to experience long COVID than the unvaccinated. But that's, again, very preliminary information. So as a result, we're looking at boosters. So far, we've been saying we should give boosters to people who are immunocompromised. And there are several reasons for this. Some people who are immunocompromised are taking medication, which reduces their body's ability to produce effective B and T cells, the memory cells in our immune system. The Bs, of course, make antibodies for future infection. And this is a problem for many of these medications. They're wonderful for people who've had transplants, people on various types of drugs to address diseases like lupus, psoriasis, inflammatory bowel disease, so on. But they unfortunately impair the ability of vaccines to give you long lasting immunity. And of course, vaccination helps you, but still, we need really a booster shot to do an even better job. And we're recognizing that immunity is waning in the general population somewhat, and therefore we should be considering boosters for everybody else. Now, The FDA has not yet approved this, but as the president announced yesterday in his 6 point plan, he is hoping to speed up this process of getting approval. Now, it is true an employer can choose to make vaccination mandatory, but there are allowances made for medical and religious exemptions, exemptions, of course, for people who truly cannot be vaccinated. But religious exemptions do exist in some states. New York State, however, does not have a religious exemption. Now, the EEOC and the Department of Justice have said that federal law does allow vaccination requirements to be made. You can, in fact, do that. The Supreme Court has not yet weighed in on this. However, the legality of mandatory immunization has existed in our law system. We used it as far back as a century ago for smallpox and fined people for not getting smallpox vaccination. And of course, well before that, even George Washington required his troops to get smallpox vaccination during the American Revolutionary War. Now, of course, an employer is able to deny exemptions for religious reasons in those states which allow it using the undue burden defense, but they would have to say accommodating someone would be more than a trivial cost. Now, of course, there are many employers who are simply waiting for the emergency use authorization to change to a full authorization. But even in places that were going by the earlier federal worker model of vaccination or testing, they were still saying, well, once it becomes fully approved, we will make it mandatory. The question, of course, arises who pays for all this extra testing? And some workplaces are indeed already doing health insurance surcharges for the unvaccinated. Now, there are people who have argued that vaccination interferes with our civil liberties, but remember, federal law has basically argued quite the opposite. After all, in a democracy, your rights end where my rights begin. And we have to recognize that we need to safeguard the general public from severe illness and death and protect the vulnerable among us, as well as safeguarding workers who have regular exposure to the public because that's the nature of their job. And we all would love to get back to life as we knew it. Also, for an employer to require proof of vaccination does not, in fact, violate HIPAA. Now, if the vaccination is mandatory, remember that the complications are covered by workers' comp. Must an employer, however, record an adverse reaction to a vaccine in their OSHA 300 log? OSHA had changed its policy a little while ago and said, not now. However, they're going to revisit this in May of 2022, and we may see something different or not by then. But of course, in a union contract, vaccination is a mandatory subject of bargaining. Now, I wanted you to know that there is, in fact, work afoot to produce a universal coronavirus vaccine to overcome the problem of a lot of the common cold viruses, as well as the different variants that could, of course, emerge in the future as well. But we don't have one yet, but there are intentions to have the first human trials begin later in 2021. So where are we right now in addressing this, the regulatory level and so on? Well, remember, we're going to draw on the hierarchy of controls, always trying to do the most effective methods we can by starting at the top of the hierarchy. Can we eliminate this disease coming into our workplace? Well, of course, vaccination helps a great deal with that. But even with regular testing, people can still be infectious before their test, is positive. So and that's a limitation of testing. And also, people can be told, stay home when you're sick and so on. Now, I can't substitute for you here on the hierarchy because I can't give you another disease in place of this one. So engineering controls like ventilation, various places where we can put up barriers, address filtration, reduce occupancy, all kinds of things that we can do here. Administrative controls relying on how people behave with their, hand washing, keeping their distance, remembering to keep their masks on their nose and mouth, and all the different procedures we do for our cleanliness and disinfection and so on. PPE, of course, very important where we have that able to be used and true PPE like N95 respirators or higher. Face masks are not PPE, they're source control because their intention is to protect other people from you, but they do give you the wearer, some protection as well. And certainly, if you're indoors around people, we want the wearing of masks simply because we need to protect the vulnerable among us. Now, of course, we have seen from past studies that when these controls are indeed well done, people are more likely to be infected from the community than at work or, of course, at school. The more barriers we put in place, the less likely it is for the disease to reach you. I love this Swiss cheese model. It's such a great illustration of each control measure we put in place producing a better and better barrier. Now, OSHA did in fact issue an emergency temporary standard, but they applied it to healthcare. They issued further guidance for non-healthcare. Now, an emergency temporary standard, which took effect June 21st, is really something that's in effect only for 6 months. And of course, once OSHA has done an emergency temporary standard, they are then obligated to work on an actual rule. So we'll explore a little bit more of that. OSHA's guidance focuses, of course, on the non healthcare workplace and helping people to protect the unvaccinated or otherwise at risk people. Now, OSHA, however, does have plans to prepare an infectious disease standard that would have broad coverage for a wide range of infectious diseases. They did one, of course, you remember, for bloodborne pathogens. This one would be heavily relying on airborne and other than bloodborne illness. Now, this one is slated to come out as a proposed rule in December. We'll see how that goes. Now, if you look at this ETS, covered healthcare employers are exempted from coverage if they, in fact, engage in non hospital ambulatory care. Everybody in their workforce is fully vaccinated. Individuals with possible COVID are prohibited from entry. And fully vaccinated employees are in well defined areas where there's no reasonable expectation they will come in contact with people with coronavirus. So there are indeed some exemptions possible even for healthcare, which raises an interesting question about the school, a school having a clinic or a nurse's office. So let's indeed take a look at that. Again, it depends on how carefully you do screen people and so on. Otherwise, your nurse's office would be covered. Now, this ETS does exactly what you would expect it does. It says you have to put together a plan and then how you're going to take care of all of these different hazard reduction measures. And I don't think that any of these are a surprise in healthcare. So, I won't go crazy about these things. Now, the guidance, of course, was how to protect people in your workforce who are unvaccinated or not fully vaccinated. And this is where employers are encouraged to consider vaccination mandates, wearing masks, and so forth, and providing ADA accommodations, and so forth. Now, yesterday, you probably heard President Biden's speech on his 6-part plan. So I'm just going to briefly show you a little bit of that. And then I'd like to take a moment to show you what people are saying is going to happen down the road. Now, this issue of vaccinating the unvaccinated, requiring larger employers to do vaccination mandates or regular testing to try to promote the use of boosters, ways to keep schools, of course, fully open by getting the states to require vaccination mandates and so on, increasing testing, and improving the care by getting more people out there to hospitals that are overwhelmed, as well as increasing the supplies of monoclonal antibody treatment. Now, here in New York State, We have seen the governor, as of this past Monday, invoke the HERO Act. Now, the HERO Act means that SARS-CoV-2 is now a designated airborne infectious agent or disease, and therefore workplaces have to put together plans for how they're going to do prevention and protection of their employees. Now, along with that is promotion of joint labor management health and safety committees. I have my next workshop in this series on committees to help you either get yours started or keep it revived and acting very well. Now, of course, the HERO Act puts in all of these various control measures that you can imagine. Again, off the hierarchy of controls, nothing particularly new and remarkable here. Really very straightforward things. And New York State has already put out draft, or rather, draft plans, in other words, that you can draw on as a template. Now, last couple things I wanted to share with you. Take a look at your collective bargaining agreement, if you have one. Now, remember, of course, past practice, bargaining history are always critical here. But let's keep in mind, if you have a contract that has some type of epidemic or catastrophe clause, most of these do not contain a clause allowing cancellation of the collective bargaining agreement or suspending the collective bargaining's various obligations. But take a look and see if yours might. Now, if you don't have, however, a clause of this sort, take a look at things that might be adapted for that use by your employer or by you. These could be references to things like acts of God, natural disasters, or other circumstances beyond the organization's control. These could give management contractual flexibility. They might allow management, for example, to alter schedules, wages, leave, other terms and conditions. Take a look at how any of these have been used in prior emergencies to see how they might be utilized now. And also revisit your vulnerable worker policies. Check your collective bargaining agreement for language on this. You may have put some stuff in for HIV/AIDS that you might be able to adapt as well. Now, is it possible for people to refuse to come to work? Yeah, it's possible. Under the OSHA Act, there's the imminent danger clause. People can join together under the National Labor Relations Act as protected concerted activity. People can request accommodations under the ADA. And of course, telework or leave and so forth. Changes to schedules of work could be accommodations. So do take a look at your health and safety committee language, startup committee if you don't have one. Put employee well-being into your policy. Remember, we're thinking that the aftermath of this pandemic will probably have a lot of mental health issues, stress related to this. Take a look at how you communicate things that are different, totally new, the benefits people might want to draw on, including those that help with work-family balance. Keep people informed about what you're doing for your mitigation strategies, and be open to these unintended consequences, especially for measures you put in place that might affect people's ability to manage their child care or home care for those who are caregivers. What about mobile workers who've had problems with restroom access, for example, and people dealing with all the problems of working longer hours or having isolation from coworkers? So I'm going to stop my share at this point. I'm afraid I did run over a few minutes, but thank you for sticking with me here. Are there any questions? I know, Veronica, you haven't fed me any. So have there been any that have come in now or any coming in at the moment?
I don't have anything. The only thing that did come in, they were asking about the recording, and Stephanie answered that in the chat, and I answered it in the Q&A.
Oh, good. Yes, the recording will be available. There will be, I think, issues that we're going to need to be open to down the road. And one of them is the problem of this disease becoming endemic. And I know people hate to think about the fact that we will be facing this disease for a long while. But the problem is, until we can get our vaccination rate up a lot higher, this is going to continue to be a disease that's going to hang around. And it's going to produce more variants, unfortunately, as people keep getting infected who are unvaccinated. So I just want to keep people in mind that there are more things coming down the road. Among them is a vaccine coupled with your annual flu shot so that you can get them all at once. Right now, the recommendation is that if you're getting your flu shot and you're going to get a booster later this fall or winter, just do them in different arms if you get them, close together in time. But otherwise, yes, keep your flu shot up to date as well. You don't want to get infected with both diseases at the same time. And we're hoping as time goes on that a number of other vaccines will see approval that might find more takers. Among them, vaccines based on monoclonal antibody technology, or rather genetic engineering technology, the way we make, for example, hepatitis B vaccine. And it's more scalable to make billions of doses, more helpful worldwide. We're hoping to see that vaccine soon. We're also seeing nasal sprays and an oral capsule, which launches the vaccine in essence for absorption in the digestive tract, and which some people may find more acceptable. So we'll have to see as time goes on.
Cynthia has a question. She's
Ah,
been,
yes.
Yeah, can you hear me?
Yes.
Okay, so based on what you just said, I now have two questions. The first question is when you were doing the screen of all the variants, there is another variant in the United States. I think it's the Lambda. So
Yes,
do you
I
have
have
any
it on the chart.
do you have any information about that and whether the vaccines are effective against that, or are there any other precautions we need to take? And then with respect to getting the flu shot and the COVID booster at the same time, I work for 1199, which is the healthcare union in New York State, and our medical director said that the CDC recommendation was to take them 30 days apart. So where did you get the information about getting it in one arm and then the other arm? Because I'm diabetic, so I normally get my immunization for the flu vaccine in October. I was going to get my booster if available and accessible in October, but I was told not to do that. So can you tell me where that information came from?
The issue of doing it, if you were to get them close together, to get them in different arms, it came from a presentation last week given by the National Academy of Medicine and American Public Health Association, and they may not have seen what this necessarily referred to what the CDC was recommending at the moment, but it keeps changing. These recommendations just keep changing so frequently. I mean, I update my PowerPoint several times every day. It's just been crazy. So, one of the things that has been noted is that we rolled out our 2-dose vaccines, the Pfizer and Moderna, with them a month between the shots. And there are people arguing that we don't usually do that with vaccines, that we give to, for example, to children. We usually wait 6 months or a year before we give a second shot. And that maybe over time, that's how we'll do our boosters, that they might be, for example, a year apart or even longer as time goes on. But again, this information, comes out literally day to day.
And what about Lambda? Do we know anything about Lambda?
Well, I haven't seen very much yet on Lambda. So I really can't speak to much of it. I've been trying to look at each of these different variants and see what the actual specific mutations were to be able to get a good idea of what has been going on with them. And I'm not really clear. Lambda was clearly, we clearly had some additional changes, but I'm not really clear whether it was going to be necessarily like more transmissible or more deadly. I don't know that I've seen anything yet on that. Um, for example, when an early variant came up in South America, beta, it shares in common one of the mutations with delta that increased transmissibility, which is why it was, or rather, beta was arrived in South Africa. But that there was real issues with how transmissible that particular mutation site was, and so this is the craziness we're dealing with. Is this as long as we have so many people, still getting infected, we're going to have more and more mutations. I'm hoping we're not running out of Greek letters of the alphabet too.
Thank you.
Okay, well, if it looks like we not getting any more questions, I will say thank you all very much for attending, and and hope you will stick with us for future topics in the series. We'll be doing a variety of different things in health and safety, and hopefully they will be of interest to you. So I will close our program at this point. Thank you very much for your compliments in the chat box. Hope to see you at a future workshop. Bye-bye.